A pristine MRI can show you a brain with perfect cortical folding, clear ventricles, and an intact vascular tree. But what it cannot tell you is whether the tissue you are looking at is actually alive. CT and MRI scans are structural maps. They cannot evaluate active metabolic function. To diagnose conditions that exist entirely in the realm of action, like the hyperexcitability of a seizure, the localized starvation of ischemia, or the metabolic decline of dementia, we have to map these invisible physiological variables. We therefore need to measure blood flow and cellular metabolism in real time. We achieve this functional mapping through nuclear medicine. By pairing radioisotopes with specific molecular carriers, we inject a tracer that acts as a beacon, broadcasting its location as it moves through the body's vascular and metabolic machinery. But the central nervous system does not simply let these chemical agents wander in. Every molecule must contend with the blood-brain barrier, a highly selective physiological blockade that dictates the rules of all nuclear neuroimaging. By selecting specific chemical agents based on their exact pharmacokinetics, specifically their ability or inability to pass through this barrier, clinicians track how the brain handles these molecules and reverse engineer complex pathologies. A structurally flawless brain on an MRI might be completely devoid of metabolic activity. Only an assay of radiotracer kinetics can clearly prove the difference between living tissue and dead anatomical architecture. Parenchymal imaging requires tracers that can actually enter the deep brain tissue. The two primary agents used for this are HMPAO and ECD. When administered into the bloodstream, both of these compounds exist in a neutral, highly lipophilic, or fat-soluble state. This lipophilic nature allows the tracers to dissolve directly through the lipid membranes of the blood-brain barrier on the first pass. Once across, distribution tightly mirrors regional cerebral blood flow, accumulating heavily in the gray matter. But crossing the barrier is only half the equation. The tracer must stay there. Once inside the brain parenchyma, these unstable lipophilic forms biochemically convert into a hydrophilic state. This chemical shift permanently traps the agents within the tissue. Though they share this mechanism, their specific behaviors differ. HMPAO washes out of the tissue relatively fast. ECD washes out much slower, exhibits better background clearance, and does not demonstrate intracerebral redistribution over time, making it the preferred agent for stroke imaging. The chemical inverse of these agents is technetium DTPA. This molecule is strictly lipophobic. It is entirely unable to cross the blood-brain barrier and is therefore restricted to the fluid compartments, acting purely as an angiographic or cerebrospinal fluid tracer. A tracer's chemical affinity acts as a precise filter. It determines whether our image maps the deep metabolic activity of the brain tissue or merely the vascular plumbing feeding it. Because tracer distribution directly maps blood flow, it can be applied to acute, time-sensitive events like seizures. A seizure is an electrical storm that drives a massive temporary spike in local perfusion. To capture this hypermetabolic ictal state, the technician must inject HMPAO or ECD within exactly 30 seconds of the seizure's onset. If the injection is delayed until between seizures, the interictal scan will falsely show the exact opposite, hypoperfusion at the seizure focus. We shift from mapping temporary hyperperfusion to proving the absolute absence of blood flow. In studies evaluating brain death, the objective is to confirm zero intracerebral perfusion, utilizing a non-crossing tracer like DTPA. This requires a strict procedural safeguard. The technician must apply a tight tourniquet around the patient's scalp. Without it, superficial perfusion flowing through the external scalp vessels could be easily mistaken for living intracerebral flow. When internal carotid flow is blocked by fatal intracranial pressure, the tracer diverts through the external carotid into the maxillary branches. This creates the hot nose sign, a secondary non-diagnostic confirmation of vascular shunting. Flow dynamics also reveal unexpected patterns in subacute stroke evaluation, typically 48 to 72 hours post-infarct. Clinicians often observe luxury perfusion, a paradoxical phenomenon where dead infarcted tissue temporarily displays excessive localized vascular dilation. To identify tissue at risk before an infarct occurs, we evaluate cerebrovascular reserve by administering acetazolamide, commonly known as Diamox. This chemical challenge forces systemic vasodilation across the entire brain. Normally, Diamox triggers a 3 to 4 times increase in perfusion. Areas that fail to increase flow appear relatively hypointense on the scan. These dark regions represent tissue operating at maximum vascular dilation just to survive, completely lacking reserve capacity and at high risk for ischemia. By actively manipulating cerebral blood flow, either through exact temporal mapping of a seizure or chemically stress testing the vessels with Diamox, we expose the hidden vulnerabilities in the brain's vascular network. In neuro-oncology, standard imaging presents a high-stakes dilemma, distinguishing recurrent tumor growth from post-treatment radiation necrosis. Both appear as abnormal masses on an MRI. To differentiate the two, nuclear medicine uses thallium-201. This tracer is a potassium analog that requires the sodium-potassium pump to enter a cell. Because this specific pump requires cellular energy to operate, thallium relies entirely on active transport. It acts as an indisputable marker of living, metabolically active tissue. A dead cell is incapable of pulling it across the membrane. Pairing this viability marker with a perfusion tracer like HMPAO generates a definitive diagnostic map based on the mismatch between vascular flow and cellular survival. This chart details the specific diagnostic matrix. High-grade tumors are actively living but poorly perfused, making them thallium hot and HMPAO cold. Radiation necrosis is entirely dead tissue, meaning it presents as both thallium cold and HMPAO cold. This viability principle resolves infectious differentials too. In immunocompromised patients, CNS lymphoma will be thallium positive, while a toxoplasmosis infection remains strictly thallium negative. In neuro-oncology, a definitive cancer diagnosis requires proving that a structural mass is actively burning energy to survive. Beyond the deep tissue, we also track the fluid dynamics of the compartments surrounding the brain. This requires bypassing the bloodstream altogether and using intrathecal administration, a lumbar puncture, to inject a strictly hydrophilic tracer, like indium-111 labeled DTPA, directly into the cerebrospinal fluid. The tracer maps normal CSF flow, at 4 hours reaching basal cisterns, by 24 washing over convexities. There is one critical rule in normal compartmental dynamics. Radiotracers ascending in the CSF should never enter the lateral ventricles. This rule establishes the diagnostic criteria for normal pressure hydrocephalus. In NPH, the tracer appears early within the lateral ventricles, persists in those ventricles well beyond 24 hours, and completely fails to ascend over the convexities. This precise compartmental tracking is easily adapted. To locate active CSF fistulas, clinicians place absorbent pledgets in the nasal cavity. If the ratio of tracer activity in the pledgets to the blood serum is greater than 1.5, an active leak is confirmed. DTPA tracking is also utilized to evaluate the patency of surgical shunts. If the tracer is injected into the tubing and takes longer than 10 minutes to flow into the peritoneum, it indicates a partial distal obstruction. When hydrophilic tracers are deliberately locked out of the brain tissue, they become the perfect diagnostic tools for mapping the integrity of the brain's external plumbing system. For the most highly detailed metabolic mapping, clinicians utilize FDG brain PET. As the gold standard metabolic equivalent to HMPAO's blood flow maps, FDG tracks cellular glucose demand and is utilized heavily in identifying specific patterns of dementia. This visual highlights how distinct dementias present as topographic deficits. Alzheimer's disease features severe metabolic loss in the posterior temporoparietal buctex. Lewy body dementia presents deficits isolated in the lateral occipital cortex, while Pick's disease presents profound decreases specifically in the frontal lobes. Mapping these subtle topographical deficits requires extreme environmental control prior to the scan. The patient must rest in a dimly lit room and strictly refrain from talking or sleeping during the uptake period. Violating these protocols degrades the target-to-background ratio. Exposing the patient to bright lights, scanning a patient with high glucose, creates artifactual competitive uptake, causing the visual and speech centers to glow and mask the underlying pathology. Every nuclear neuroimaging study functions as a precise biochemical assay. Its accuracy depends on controlling the patient's physiological state to isolate the brain's functional variables.